Israel Owolabi, please mute your line. Thank you. Damilola, Daramola, please mute your line. Okay. Juliet.
I come in before to check money. I didn't know you were still outside. I thought you were outside. So I continued drinking. I had an order from home, so I just finished. I made coconut rice in the afternoon.
Okay, we want coconut rice too. Mute your line and send the coconut rice. Okay, Dr. Oshodi.
Okay, please just give me 2 minutes. I'm coming.
All right.
Please.
Okay. Okay. When you are ready, we are ready. Quarantine.
Okay, good evening, everybody.
Okay, good evening, ma. I think they are muted. Yeah, their lines are muted.
Okay. Good evening, everyone. We're all welcome. Dr. Ekpere is helping me to share my slides. I need that help. So this evening, we're going to talk about psychological first aid. And it's important that we do this because it's actually an important aspect of what we do, and it's a tool that we're going to have to utilize, you know, in our interactions with these patients, either, you know, as inpatients or whether they've been discharged, or if they are in the community and they're experiencing distress following this. Okay. Now, psychological first aid itself is really an evidence-based strategy that I'll describe in a bit more detail as we go on. Can we have the next slide, please? I know some of us may be familiar with this, you know, to varying degrees. Dr. Ekpere, can you please transit to the next slide? While others may just be hearing about it for the first time. So, okay, look, Dr. Biahu, are you the one sharing the slides, please? Are you the one? Who is helping with the slides? Oh?
Yes, ma'am, I believe the slides.
Is that Dr. Biahu or is it Dr. Ekpere or is it Dr. Oni now? I'm sorry? Dr. Biahu, okay, I need you to just, you know, move with the prompts, okay? You know,
okay,
you're like my hands now. So,
okay,
all right, can we go to the next slide? Is there a problem with it? Okay, I don't know what the issue is, but I will try and just go on while Dr. Biahu
Dr.
sorts
Oshodi,
that
you can
out.
go on. You can go on. I'm sure you have
Yes,
something that will follow
yes,
you up.
yes. Okay, so it's important that we realize that there are different kinds of distressing events that individuals can face. And we see and hear of these events all around the world, you know, the world around us. We hear of wars, we hear of interpersonal violence, you know, natural disasters, and even a pandemic like this begins to equate to something similar as these disasters. Even though it's not like, you know, it's not like a bomb blast that is killing people right before you. It's having similar effects on people, you know, around us. So everyone is affected in some way by these events, you know, and to varying degrees. And because of the fact that it's varying degrees, there'll be a wide range of reactions. And that also would inform how we adapt whatever we're doing to suit these wide range of, you know, reactions that we may see. A lot of people may feel overwhelmed, confused, or very uncertain about what's happening, fearful, have questions, and really feel there's a threat to their life. And for some people, the worst is over. For others, it may just be starting when they begin to have symptoms, where they begin to think, could this be the end? Or when they receive a diagnosis, could this mean death? So these traumatic responses begin to kick in. Some people may have mild reactions, you know, like we have also seen. And my slide has just gone off the screen. So we will hopefully get that sorted out in a minute. Okay, so some people may have mild reactions like we've seen. For those that have been taking calls, you see that while you have some people that are calm and, you know, together and they receive this experience, you know, well, you have others that, you know, take it out on you and really react in ways that may appear almost out of proportion to what you are seeing. So how do people react to distress? What informs this reaction to distress? It depends on varying factors. For those of us that are not core mental health people on the team, maybe you've been counseling and all that, it's nice to understand that there are usually some factors behind why individual A may respond in one way and individual B may respond in a completely different way. First of all, the nature and severity of the events that they're experiencing. You can have 10 people exposed to one event, but exposed to it to different levels of severity. And that can impact or inform how they respond. Or their experience with previous distressing events. Don't forget that these people that we're seeing, we don't have the benefit of their past. We don't have the benefit of understanding their personality before now. We don't have the benefit of knowing what their life experiences have been before this current exposure that they're having. And the kind of support that they've also enjoyed in life from others. Have there been people they can rely on? Have there been people that have been dependable around them? You know, all that gives us a sense. When you have that kind of support, there's a bit of reassurance and calm that could be present in that kind of person, unlike the other person who knows that, well, in this life, I have nobody.
Oh, please mute your line.
Someone really needs to mute their mic for us. Okay. Dr. Abiodun, Dr. Keshiro, Dr. Fatiregun, Oluwatoyosi, please can you mute your mic? Please mute your mic, please. Dr. Joe probably needs to help with that. All right, so, okay. So also their physical health. What's their current physical health? Someone that is already struggling with some health conditions, maybe a little bit more vulnerable to others. You know, maybe they've gone through a lot of ill health and anxiety along with that could also inform why they react certain ways. Their personal and family history of mental health problems. Don't forget that these individuals that are faced with trauma may be entitled to have a past history of mental health prior to that trauma. It could be depression, anxiety, something that they've been sitting and they've been doing fairly well with, you know, but you now have a layer of this traumatic experience or this pandemic or this diagnosis that comes to them. That becomes another layer of distress for them. Their cultural background and traditions, and their age. You know, the way a child would respond may be slightly different from that of an adult. And these are all things that would be playing in the background why this person sitting before you is behaving this way. So psychological first aid itself is actually an intervention that has been designed for assisting people that have experienced, you know, in the immediate aftermath of maybe a disaster or something life-threatening to them that is causing initial distress. And the aim is so that it doesn't result in malfunctioning in the long term, okay? Essentially, you want to foster short-term and long-term function. You want to be able to restore that as quickly as possible. So it's a humane and supportive and practical assistance that is given to a person who has recently suffered a stressor, a significant stressor. And I remember this is with the backdrop of what I said before. This was designed for disasters, earthquakes, wars, you know, bomb blasts, you know, shootings. So we are now utilizing this in a situation like this because this experience itself has been described by many to be trauma in itself that people are sitting with and living with. It's non-intrusive and it's practical. It's practical care. It requires or it utilizes the assessment of the needs and concerns of the person you're dealing with. It is to help people address their basic needs of food, water, basic needs, you know, what should I do, who should I talk to kind of thing. It should be more of a listening process, not that you're necessarily going to pressurize people to talk if they don't want to. Your aim is essentially more of comforting them and helping them to feel calm, helping people to connect with information, services, and social support, and protecting them from further harm. You can see there are several aspects of it, but there's a general feel of it. It's just, how can I keep you safe immediately after what you've gone through? Safe physically, emotionally, and mentally in the immediate aftermath of this. The other thing about it is that it's really to help them feel calm and supported, okay, and to cope better with the challenges that may recur following this experience that they've had, and to help them manage their situation and make informed decisions. It's important because it's almost like almost like when you give first aid when someone has a cut or, you know, an accident, which is not the main treatment itself, but at least it prevents further harm. That's the way we should see it, okay? It's almost like that. It's almost like a first aid that's administered. It's a first-line psychosocial support for people affected by crisis events. So for those that may wonder, is it just all talk? There is actually evidence backing its effectiveness, okay? It's described as an evidence-informed approach that can help all ranges, okay? That's children, adolescents, adults, families following this exposure. And some of the standards, it meets some basic standards, okay? And some of the standards include the fact that it's consistent and has research evidence, okay? That it can help to provide some resilience following trauma. It's also applicable and practical anywhere on the field. And we must see ourselves as being on the field right now with what we are doing. And it's also appropriate, you know, for all developmental levels. So it's not just something that you use for just adults. It can also work with adolescents and children. And it's been found to be culturally, you know, usable, and it's flexible. So it's not like, okay, it's only white people that have used it successfully. It's a way that we can also use here. So it definitely is not something that only mental health professionals can do. So this is to underscore the fact that lay people can be trained in deploying this form of first aid. When I say lay people, that means that you're not called mental health, but once you have this understanding, it's something that can be deployed. It's not professional counseling. It's not just because people are actually trained, you know, to either offer counseling or offer psychotherapy or, you know, different clinical or psychiatric assessments. Psychological first aid is none of that, okay? So those are higher levels of mental health support that you require a bit more specialized training to deploy. It's not psychological debriefing, because once upon a time the word debriefing was used a lot in conjunction with trauma, that we must debrief the person. But there's research to show that debriefing can actually be more harmful than any good that it has to offer. So, and also you're not going to engage the person and say, okay, start analyzing, tell me what happened, tell me time by time, minute by minute, per second per second. It definitely is not that. And it's also not the art of pressurizing them, okay, talk to me. Remember what one of the first slides I said before, that it's not about pressurizing people to communicate when they do not feel like it. So it involves paying attention to reactions. It involves active listening. And if needed, if there's practical assistance that's needed, deploying of such, providing problem-solving skills, and further options for assistance. For those of you that have been doing what we are doing over the last few weeks, and those of you that have observed, you know, even up till date, you see that there are many components of what we've been carrying out in this psychological first aid.
Please mute your mic.
When deployed well, it should help to normalize worry and other emotions in the clients that you're helping, and it should also promote healthy coping feelings of safety and calming and hope. So there are some steps to it and some components to it. So with all that talk, it's just to mention that essentially what we want to do is to help the person to learn to cope and to be able to move beyond whatever experience that they're having going forward. And there's some key components that you want to achieve in your psychological first aid. You want to be able to create a sense of safety for the person that you're dealing with. You know, it's normal that there is a flight or fright system in the brain that stressful situations trigger. You know, a bomb blast or a house collapse, people want to run for their lives, their hearts are beating fast. Those are the normal physiological responses that kick in. And by the time the person reacts to that thing, you want to then reassure that you'll be fine, things will be fine, you know, just let's take it a step at a time. I'm here to support you, I'm here to help you. So if you can just juxtapose that experience to someone that you break the bad news of coronavirus to and starts freaking out and screaming and saying all sorts of things, you know, that, you know, yeah, they're going to die, or they're abusing and they're aggressive. It helps to understand that this that you're seeing, that reaction may well be that fight or flight response, okay, that the individual has triggered, you know, in response to this stressful thing that they're faced with. You also want to help that client to experience calm. You want to create a calm, and it really starts from your voice, okay? Someone cannot be speaking a notch so high and you're matching the, madam, keep quiet, listen to me. No, there has to be calm, and calm in your voice, calm in your sense with empathy and all those things that can give a reassurance of calm and bring that calmness into the situation is important. I guess I'm aware that there may be situations that will defy these things, but I promise you those are oftentimes the exception and not the rule. You want to also create a sense of self and collective efficacy. That means that efficacy is from the word effective, you know, efficient, that as an individual self and as a collective, either a community, we can still be effective in spite of what we're facing. That means there are still things within the person's power that they can do. For example, self-efficacy could mean that you can still take care of your personal self, you can cook, you can still have capacity. For our clients, for example, it can be that you can still keep safe while at home. It doesn't mean that you're completely helpless. Hey, help me, what do I do? I don't know what to do, you know, that sense of helplessness can actually worsen the individual. Is anybody hearing me, please? Can anyone hear me? Hello?
Yes, ma, we
Hello?
can hear you, ma.
We can
Okay.
hear you
All
now.
right. Thank you. Thank you. I was getting a prompt on my phone that some
Yes.
data has finished. Okay. So you also want to create. Yes, I can hear you. I can hear you. I can hear you. Thank you. Yeah, I heard though.
We are meeting our mics again, no?
Okay, sorry. Mute your mic. Thank you. Okay, so you also want to help that individual create connection to resources around them so that they don't feel. I remember there was a chap that we reached out to he lives alone, he didn't have a car, he couldn't get to an isolation unit, and he was just there alone by himself. So we become that connector. Okay, don't worry, we're going to help make a call, we're going to help to see what we can do, we're going to help you inquire about this. Have you thought about doing that? Have you thought so help them create connections, useful connections that can still be useful in this current time and this space in which they find themselves, and also create a sense of hope. So this next slide also has a long list of quite, a bit of similar, items. It spread it, a bit more, but it generally still speaks to the same things that I had mentioned earlier on. So I want to, if you take a closer look at the list prior, so we're talking about safety. I actually like this one because it's easier to remember: safety, calm, efficacy, connection, and hope. So in all your discussion and your interaction with the person, just think about that. How can I put a band-aid on what this person is going through? I must help the person understand that they are going to be safe, they are going to be fine. Help them, be calm. Let them understand that when they panic, they stop thinking. When they stop thinking, they make mistakes. That's when people start drinking disinfectant, they start taking salt, they start bathing in chloroquine, all sorts of, all those crazy things. Is because there's a fight and flight response. So you want to create a calm, and you want to help them understand that they still have a sense of self-efficacy and collective efficacy, and establish connections for them and hope. So I think if there's any acronym or letters you need to remember just to keep this at the back, I think this will be the briefer version. The one on the next slide is a little bit longer. You can move to that one now. I think it's essentially covers almost the same thing. Protect them from further harm. That speaks to the one of safety that we spoke about. Opportunity to talk without pressure. So, remember when Dr. Mel was talking about breaking bad news, generally you need to be able to listen more. You don't have to just be the one talking. It's a skill in mental health support and delivery that you must be an active listener. You cannot be the kind of person that just wants the person to finish talking and then you say your bit. So allow them opportunity to talk without pressure if they want to, and if they don't want to, then just make do with what they've told you and try and see how you can help. Be an active listener. You must demonstrate compassion, and I must add empathy. At this time, empathy is a very important piece. Empathy is the ability to really step into that next person's pair of shoes. And I think we were reminded yesterday to not say, oh, I know how it feels. No, you don't know how it feels, but you can suggest that. I can imagine, it sounds like this must be really hard. It sounds like you must be struggling. It sounds like this is very upsetting. It's good, it helps at times just to mirror back what the person has said. Actually, you sound very angry, and I think I from what you've said, I can see where you're coming from, how it can make you angry. So it's just endorsing whatever feelings they're expressing, and then you go on to see whether there's anything you want to clarify. Address and acknowledge their concerns. Remember, we're talking about helping them to be able to see that there is hope and there is, efficacy. Is there something that can be done? So don't just wash away or ignore their concerns, okay? Address and acknowledge concerns, okay? Discuss coping strategies. That's part of self-efficacy. There are things that they can do within themselves. Discuss it. Do you know that there are certain things that you can still do that can help you? And I think that will be a talk that will like we had said at the beginning of these sessions, that we usually have these talks every week just to continue to build capacity. So useful coping strategies may be a talk that we'll put on the queue, somewhere down the line going forward, and we can have a review of that so that we're all up to speed on that. Encourage them that there's whatever social support is necessary. You may need to be the one to activate that social support for them by connecting them to this available support. And as we said yesterday, it's okay not to have all the answers, okay? It's okay to just say, you know what, I promise I'm going to call you back. I will just check and I'll send you a message. I'll call you back on this question that you've raised. I'll find out from the other members of the team. That's fine, to do. So that you can always escalate and we can provide guidance because really, we don't know all the different issues that people will come up with. And we're not saying that we have all the answers either, but at least let's see what we can do to provide whatever support is possible. Offer them that they can always return back to talk to you if for any reason they don't want to talk now. There was the one patient, I think one of the therapists, I think it was Adebaki, he passed her on to me. She was a very furious young lady and didn't believe anything about COVID-19, abused everybody in it, said we're all thieves. He handed the case over to me. I called her. I thought I was making headway. She gave me exactly the same treatment. And eventually I just told her, you know what, you can always still feel free to call back anytime you feel, you need to, And that was it. We just had to leave it like that. If she does call back, one won't react in any way to her. One will just pick it up from there and see how to help. So I think it's something we can do for all our patients. So remote psychological first aid. So really, when this the delivery of this is usually face to face. Most times in other settings when this is done, okay, it's a face to face thing. But in a situation where you cannot do face to face in the face of a contagion like this, viral risk of viral, contact or infection. So we're having to utilize remote psychological first aid, and this has been recognized. Okay, it's an option in the context of COVID-19. So we are having the talk between the helpers and the affected will take place on phones or online media. In other settings, you have platforms, technological platforms that have been set up, and you can have that interaction. The only exception to this in COVID-19 would be when we are maybe providing support for health frontline workers. For example, there could be colleagues at work, there could be workers you need to meet with in groups and all that. So that may be an exception. It doesn't mean that you can't help frontline health workers remotely, but you can also probably have group sessions with them, maybe in a hall or something, depending on the needs of the setting. Now, in addition to handling the practical and emotional fears and worries of the virus, there are other related issues. There's an increase of child abuse, domestic and intimate partner violence, substance abuse, anxiety related. All these things are also issues that may trigger, because they're also abuse, they're trauma, and some forms of psychological first aid may also be needed to be deployed there. Some of the steps would be simple things that I've mentioned, but I'll just reiterate again, maybe in other words. So you're making your first contact and engagement. You're not going to pressurize and say, talk to me, in the course of doing that, you're ensuring safety and some comfort and reassurance. Each time, I remember early days of doing this, some of the counselors raise issues and say, look, the biggest part of our work is reassurance. Reassure. Honestly, because you reassure today, it doesn't mean that same person you're not going to reassure tomorrow. I see even doctors, they're struggling. You reassure them today, then 3 days down the line, they're still like, I'm not sure I want to go to work. I'm afraid of this, I'm afraid of that. It's reassurance. We're not going to force anyone to do it. So a lot of reassurance. You may need to gather any
Can't hear you. We can't hear you, ma.
Hello, Dr. Oshodi.
Hello, ma.
Dr. Oshodi. All right, don't worry, she will soon be back. I think she
Okay.
has connection problem.
Yes, I think my line just went off. I'm sorry.
So you
Okay.
have to go back as far as
Where did I
reassuring,
disappear?
as far as reassuring and reassuring and reassuring.
Reassuring. Okay.
Yeah.
Yes, I think it's. I was talking about safety and comfort. Because you may be thinking, okay, what are the steps? So you make the contact, okay, and you engage. From that engagement, you have a feel of, is this person ready to talk? And remember, if the person is not ready, you don't force it. But for those of you that are in disclosure, yes, you probably need to still have your conversation. But remember the role play that was done yesterday. But the thing about that is there's a thinking around your interaction with your clients at every level. That's what this is speaking to. And see how you can stabilize. When I was talking about practical assistance, that the practical assistance that is required in an earthquake situation, maybe, oh, we need clothes. Did I say that before I went off? Did I say that? You need clothes, you need to rebuild your house. Can anyone help me? Okay, I didn't say that. Okay. So in an earthquake situation, a practical assistance may be something like, oh, your house is collapsed, we need to help you rebuild it, or you need clothing, or you need food. Those could be practical assistances. Now, in a case of COVID outbreak like this, what does practical assistance look like? Oh, I need information. What do I do? Where do I go? So those are lots of questions that I know they've been flagging to us, and we've been able to answer some. We haven't been able to answer some. I remember there were one or two cases that Ms. Saikomo flagged also early days that were actually struggling with food, and we're thinking maybe we should even approach food bank to see how they can assist with that. But it's a bit tricky because we'll kind of be stepping out of our bounds, in doing some of those things if we don't have the state support to do that. So we couldn't fully explore that, but that's a kind of practical assistance. So if we discussed with the IM if they could write a letter to the food bank, and there was that arrangement. Exactly, that would be the kind of thing. We just channel it to those that we come across in that situation. But in the absence of approvals like that, in this kind of response, we have to just be careful till we get approvals. Connect them. Remember, we said networks. Connect. See what are the social supports and networks you can link them to, and then assist with that. Okay. All right. Next slide as I begin to round up. So, who do we give this psychological first aid to? So, even though everyone may require it at some time, at some point during this, you may need to give it to specific people, and those are the people that essentially are being flagged for. People that are self-quarantined, either they're in homes or in appointed facilities. The general population, if they call and they say, I don't know what to do, is like, there's something, there's an outbreak in my compound, and all that, or I'm afraid I'm going to catch this, or I'm depressed, whatever the issue is, and they're calling helplines. Health workers and social welfare responders are also will also be in need and will require support of psychological first aid. Persons who have recovered from COVID-19, families and friends of diseased persons. Now that's a group that really we don't even have their contact, so we don't know what to, how to really reach them, because most of the contacts we have on record are contacts of the individual, and once the person passes, the contact of the of the family is not readily accessible. But now that we met him, maybe something we need to still see how we can, if there's a way we can track further. Caregivers with children, at home, due to closure of schools, they also have their own levels of struggle that they are going through. So I just have a slide or two, then I'll be done. Can I have the next slide? I think I've gone through some of these slides, sort of, because in when you think about delivery of psychological first, we need to also have a structure. And we do have a structure right now. So we're a team, and we need to understand the principles which we've done, and the intervention plans for categories which we already have in place, and we're building up these teams to deliver this in our interventions. I think that is all. Is there one more slide? There's okay. On that note, I just want to remind us about some do's and don'ts. I'm sorry the slide is so tiny, you can hardly read it. Some of the don'ts, let me start with the don'ts. Don't pressure people to speak if they don't want to speak, okay? You tell me more. You don't want to be judgmental. It's important we try and avoid using technical terminologies. You know that the people we interact with, they are varying levels of education or literacy. It's important to really avoid talking about your own self, or personal issues or troubles. Now, wow, this COVID thing. For me too, I was even scared. In fact, I'm even afraid as I am. I don't mind them. You brought your own matter into the case now. Don't give false promises or false assurances, and we need to try as much as possible not to share someone else's story or experiences or exploit the trust. The do's are fairly straightforward. Ask gentle and probing questions. Use open-ended questions when you need someone to give you more information. Can you tell me more? Why was that? Where? How? Words like that. How, what, when. You'll get a bit more information that way. Acknowledge and recognize the feelings and understanding of the events that the person is going through. Someone says, hey, can you imagine I did my test 3 weeks ago and they're just sending results to me now? What kind of nonsense is that? I can understand why it's very annoying, that if it had come out a bit earlier, definitely will have helped that. But now that it's like this, what do we do? So you acknowledge it, recognize it, don't ignore it. Don't say, well, be happy that you even got a result. Some people don't even have results. So, empathy, acknowledgement, and recognizing it. Recognize the internal resources of the person and highlight the capacity to cope, where you can recognize that and highlight it to the person. Provide information about COVID-19, honest about what you don't know. And it's okay to just say, it's actually a new virus that we're all learning about, so things may still not be very clear, but everyone is trying their best. Everyone is trying. In fact, a few times I've had to tell patients that are really, especially the inpatients, they're really furious. No doctor see me, and it's people are really trying their best. Actually, some of the doctors in that center are actually also struggling with this, because it's not easy for anyone. The doctors are just doing their best to come to work, and that alone at times it douses their stress. They realize that, okay, maybe they're being a bit unreasonable. Or let them know that if they don't have PPEs, it's hard for them. Maybe the PPEs are not enough, so they're just trying to, so they can only come in once or twice. Because patients are inpatient, at times they don't get it. It's an isolation unit. That means that nurses don't just come at your beck and call. They can only come in maybe once or twice a day. And each time they come, once they wear that hazmat suit, it costs 100,000 or more. That whole gear. Once they wear it and they come out, that's it, it's gone. So they cannot do that more than once or twice a day. So the people, they question and they're frustrating. They're frustrated without having that understanding. Allow them to process and ventilate their emotions. Listen for their own options, and you can also help them make choice. Have you thought about this? Would this be a better option? For example, someone says to you that my child, I don't know what to do with my child. Okay, what are the options? Is there anyone your child? No, there's no one. No one's going to take her. Okay, so that's out. What other options are there? Is there anyone at home? No one at home. So maybe the child has to go into the unit with you. And we've had cases like that where moms and children went in. Mom was negative, a child was positive, or a child was negative and mom was positive. Ensure that we do no harm, and that principle must be upheld as much as possible. So on that note, I will stop and hope that I can answer any questions that you have now. Thank you.
Thank you very much, Dr. Oshodi.
Thank you.
Very insightful and beautiful presentation. And your sweet voice that will make everybody to listen.
Okay, now.
All
Thank
right.
you,
So,
Dr. Oshodi.
yes, ma. Okay, I think I have some questions for you already.
All right.
Okay. Um,
Yes, please, let me have them.
okay. The first question. Sorry. Okay.
Can
What can
everybody
we
hear
do?
me? Can everyone hear me?
Yes, ma'am.
Yes,
I
we
got a
can.
message. Okay. All right, just checking that you can hear me. All right,
Okay.
go on, please.
What
Okay.
can we do? What can we do to a patient that wants verification of their results for work? For work, some people want their result through email. Also, what
Okay.
can they use while self-isolating at home? Then, please, ma, can
Okay.
we get the slides? Oh, sure, you can get the slides. Okay.
Okay, so for the slides, yes, you'll get the slides. It will be put on the chart and you can pick it from there from time to time. And you know that we have like 3 groups right now. We're going to have a bit more, but there's a volunteer group. On that group, we'll just be dumping useful information. Okay, that's different from the working group, so you put the results. For those of you that don't know how to navigate on WhatsApp, if you go to the group page, you know, apart from where you post things, you can actually say view all media. So anything that has been posted on that group, even if it was 5 months ago, once you haven't deleted from your chat, you can see all those things and pick them. Because I get people asking and asking again what we've shared, and it's actually sitting there on the group chat. So people are asking for verification of their positive results. I mean, negative results is not a problem because the labs are sending the results to them, and at discharge, the lab has also started helping us with discharge letters. But the positive results were not being documented by the lab. But we made a request. I think this week I got quite a bit of pressured requests around that. So Dr. Saka, who is one of the people in the lab, has promised that once we can collate, you know, the request for positive letters, they can make that available. So we need that list collated. I think Team A and Team B, they both should have a social worker designated to help in collating those requests during your work week. And it's important we collate it so that it's not just hanging all around the place. So for example, Mr. Ebosele, please, you need to mute your mic. Your mic is on and there's an echo coming in from there. Thank you. Okay, the echo is very loud now. Please kindly mute your mic. Okay, so I've lost my train of thought now. So I was going to say that we need, once we have someone who collates these requests for us, so let's say you're in disclosure or you're in inpatient or you're in whatever, there's a coordinator, just put that request. I have this patient that has this request, put it on the chat and also private chat your team lead that we need that. And then we need a designated social. I think Mr. Ikomo does for team A. We need someone else in team B who will collect it so that once if we have like 4 or 5 names, maybe by Wednesday, we can send to Dr. Saka. He will do it while we're working out a more a smoother process. Like I said, these requests have just started coming a bit more actively in the last week or so. What I have suggested to him is, as they put the results, they should just give us a folder with all the letters already prepared so we can pick from there. But we all agree with me, that's another layer of work for us. We don't need to be sifting through 3,000, 4,000 positive results because the list now is over 4,000 names, you know, that are on that list. So we need to be sieving through that. That becomes a big problem. So let's work with this now. Let's try and make it work. You have those requests, put it in your report, then also escalate and try and build what the issue is in that short WhatsApp report so that the social worker designated to help with that can be flagged. And I think on the chat we also highlight who is who that can help with that. There was a second question which I don't know if I've answered, you know. Yes.
Well, I don't. You did not, but what can they use while
What can
self-isolating?
they use while self-isolating? Now, to remember that if you're not a, a doctor to prescribe, it becomes a very tricky thing because these people you are dealing with are very funny. The next thing they'll say, a psychological thing, they're the ones that say I should do this. You know, they're the ones that are prescribing. So we need, and I still raise it at EOC today, that what is the position of caring at home? We need a protocol that's coming from the center that we can use. And there's no clear go ahead on that yet. But there's some safe things that people are doing that we can just say, well, we are not the doctors, you know, per se. Our job is just psychological support. But there's some basic things that have been found helpful. Lots of fruits, eat healthy, keep warm, you know, drink your ginger and whatever. All those things are not harmful. I don't think they're harmful. You know, you can easily say that. So you're not prescribing anything that's medication, but they're harmful and they're helpful remedies that we've received anecdotal reports about, and let them know that we're hoping that the doctors will be in touch soon. I must mention that there's something that we're also trying to work on as a team. The coordinators and the team leads are still actively discussing this. We want to see how we can pull out those that are still at home, maybe mild symptoms, and they're not going into isolation units.
Mute your mic.
He's MIA. A lot of people are concerned for his well-being. So what the fuck would I know about that? Well, as coincidence would have it, he was last seen in New Jersey. So was the Hindenburg. Maybe you want to look into that.
All right.
Tony, please. Phil.
Mr. Chantel Ebosele.
I grew up in this guy's.
Okay.
And I just lost my
Well, we're struggling a bit here, but I hope I'm clear. So we're working on a platform where we can maybe have group sessions, virtual group sessions with those at home. We're still trying to work around that so that those group sessions we'll probably invite someone from case management who are the doctors on the wards to actually speak to the patients and let them know that, okay, you're at home, you can do this, you can do that, you don't need medication. You know, knowledge is power. Once you just give it, their anxiety and stress levels may go down. And so we're exploring. Thank you for muting your mic. Thank you. May go down a bit. So that's for those at home. Over to you, Dr. Oshodi.
Question. You have another question. If the husband is requesting for the results of wife, but the woman insists we should not give him, how can one undo this?
Well, husband cannot demand for anything because it's like doing an HIV test. It's the person that does the test that receives it. So you are not, it's the individual that you give the result to. So I don't see there's no conflict. You don't owe the husband anything. The husband is not your client. And if a patient has been assigned to us, our business is with that patient, not with the next of kin. So we need to be careful also that at times you may find out that you call a number and a family member picks up the phone. We must tactfully just ask the person that I really want to talk to this person. To make it urgent, you can say that I'm from the COVID-19 response. Just tell her to call me back and we'll take it from there. Now, we know that some people may pretend. That's another thing. We've had cases like that. And later they'll say, it wasn't actually me, it was my, you know, that one was not in our control. But once we know that it's not the index person we are trying to reach that has picked the call, let's wait till we can talk to that person and request to speak to that person directly. All right.
Thank you very much. Do we have any question? If you have any question, please signify by raising up your hand so I can call you. Okay. Okay, I don't think there's any question. Okay.
All right.
All right.
That's fine. Thank you very much.
Thank you very much.
Thank you. Thank you, everyone.
Oh, I think it's been a very busy week, but I believe it's really it's been a very productive for the new volunteers too. Yes. All right, volunteers. In fact, I know that Dr. Oshodi was very, very busy today, but despite that, she was here for us. So can you unmute and give her, let's encourage her
This is our trap.
Thank you.
Let me remove our speaker.
Thank you so
Thank you very
much.
much.
Thank you.
Thank you,
Thank
Dr.
you, everyone.
Thank you,
Thank
ma.
you very much.
Thank you very
Thank you,
much.
ma'am.
Someone is
Have a
asking when is
nice
Team
day,
B
ma.
starting?
Thank you, ma.
Thank you very much,
Thank you,
ma.
everyone.
Thank you, ma.
Appreciate you all.
Thank you, ma.
On behalf
Thank
of
you
the
very much.
psychosocial team, we're all grateful. All
Thank
of
you,
us,
ma. Yes, ma.
yes,
Thank
we're grateful for all we do. We need to appreciate ourselves. Someone asked when
Yes,
is
ma.
Team B starting? Dr. Shokunbi,
Yes.
when is Team B starting? They're asking.
I
Thank
said
you, ma.
yesterday that we're starting tomorrow, and by the grace of God, we will still start tomorrow. Don't worry, it will be gradual.
Amen.
All
It
right?
will be gradual. And we're there with you, okay? Team A is there. We've got your back. We're working with you.
We're working
We're
together.
doing a lot of hand holding over the next week. Even though we're going to try and rest, we'll try and put our feet up, but we got your back. We're there with you. So thank you, everyone.
All right. So please, your WhatsApp, make sure you check your
Well
WhatsApp.
done.
Yeah, I mean, till tomorrow morning. You can get anything from midnight today, tomorrow morning till maybe 12. I believe Dr. Oshodi. Yeah. All
We
right.
are ready. We are ready.
You are ready.
Someone put a question. They're ready.
All right.
See,
So
someone asked. Let me tell Dr. Shokubi. There's a question there. Are we going to use our personal phones?
That's what I want.
I think let me put
now.
Yes, let me just put a context a bit to that before you then address the hopeful nature that you're bringing to the table. That you see, when Team A started, we actually had to use our personal lines, and many of us are still using our personal lines to call. Out of 110 people, it's only 15 people, 15, that have MTN branded phones that were given to us. So right beyond that, all the others are using their personal lines. What some people have done, maybe they use a second line so that it's not their regular line, or they use their personal lines. Airtime, you may need to start with a little of your own airtime. I think Dr. Shokubi has some lovely news to give everyone, which I'll let her know. But just to reassure you that whatever inconvenience is experienced at the start, there's a lot of work going on in the background to make sure it's relieved, please. But it's really, we're doing this because our heart is here. And that's the only thing that will take us through. Because once you, and if you're really struggling, we've also had stories where we said, don't give this person calls for a while, because it's clear that you can't go beyond yourself, literally, if that's going to. So, so please just understand that concept. We're not asking you to, we don't want you to, you understand what I'm saying, Dr. Shukri? Over to you.
I think you have said it all. This week,
please, I have small question to ask.
Let me finish.
Oh, sorry, ma.
Okay, ask your question.
Oh, okay. Good evening, ma. Good evening. Can you hear me, ma?
Good evening. Yeah.
Yeah. My name is Immaculata.
Okay.
Yeah, the question. Hello.
Go on, please.
Oh, okay.
Yes,
I called someone the other day. And when during interaction, I came to the person told me that he mentioned my area. You understand? So I want to ask, if you come in contact with someone who you know, what are you going to do? Maybe you just called and the person's name showed your true color. So what are you going to do at that point in time? Are you going to refer? What are you going to do?
Let me try to speak to that, because I've been in that situation, and I'm in that situation many, many times. First of all, in that situation from the angle that one just being on this team, it's what it is. You're on this team, and if you have to break it to someone that you know, it's from the angle, this is an official thing that you're doing. That's one. So I've had to break it to colleagues, and I start by letting them know that I'm doing this work, and I'm here to support. And colleagues that we were not necessarily close, so we don't necessarily have to be friends. And incidentally, there was one random person that was assigned that I was managing as an inpatient, in the early days. And when I finished breaking, he said, "You know what? I think I know you. I think we were classmates in secondary school. Is it not? You know, so and so, Miss so and so and so. Then I said, okay, yes. And I was able to support him throughout the admission, So I didn't, it wasn't, it's work. Sure, you understand? You're not prying into someone's privacy. It's just what it is. So if you happen to be assigned someone that's in that, that falls into that category, you can go ahead. There's nothing that says you can't. But if you as a person think you may struggle, or this person may not, you can flag it and we'll take it off you.
Yeah.
So there's nothing to say you cannot do it, okay? But if you feel that there's this person won't just flow, it won't flow at all. We know how there's some people that it's not just right, it doesn't fit. So just escalate it and the person will be taken off. So that would be my answer to that.
All right, thank you very much, Ma.
Thank you, Ma.
Okay, so
You're welcome.
the good news that Dr. Oshodi is talking about is that we have someone has donated 100 phones.
Oh, that's good.
Shout hallelujah! Nobody's shouting.
However, like a little process. Yeah.
Yes. How? Oh yeah, mute. Let's hear the however. Mute.
However, yes, there's a process involved.
To God be the glory.
That's why I said this week, I think we will still have to use our phone and our recharge card airtime. But if the process is going to be too cumbersome, I can assure you that we'll just give it out next week by the grace of God. And I want to also believe that you will have recharge card or your lines loaded by the end of the week too, by the grace of God.
Somebody shout another hallelujah. Mute your mic.
Hallelujah.
Mute your mic before Dr. Oshodi drives us.
Thank you for your effort, Ma.
Well done, Dr. Shokumbi. Well done, Dr. Oshodi.
Thank God. Yeah. But if you have issues, if you think that you won't be able to cope this week, like Dr. Oshodi said, please let us know so that we just
Thank you for the job well done.
next week. Yeah. All right. So thank you very much for your participation. It's been a very good, productive night. There won't be any presentation tomorrow. Work starts tomorrow. So are we meeting on Tuesday?
Yes, we usually for the general team meetings, we meet on Tuesdays, okay? Then the coordinators and the team leads meet on Fridays. And the Tuesday session will usually be a session where we express, our experiences. Usually it's anchored by the assistant team leads, and that will be Dr. Ome and Dr. Ajomale will anchor that meeting. And also it's an opportunity to have capacity building sessions. So Dr. Fashanu will probably use that opportunity to give a talk on some of the guidance for the calls, okay? We'll just skip tomorrow. Let's just try and cut our teeth on this tomorrow. So Dr. Fashanu will she's given the talk before, so she'll just go over it again, what the different calls look like. And it's a working document. So I want you to, it's a living document in the sense that we use it 2 weeks down the line, we see there's a missing piece, we need to add it, and we adjust it and we share it again. We're also working on putting together frequently asked questions. Please, we haven't forgotten, so please know that it will come out soon. So we meet on Tuesday. Thank you.
Yeah.
Thank you, ma'am.
Thank you very much. Have a beautiful, peaceful, and restful night. Thank you, Dr. Oshodi, one more time.
Thank you, everyone. God Good night. You. Thank you, Dr. Oshodi. God bless you.
Thank you, ma'am.
Good night, everyone.
Good night, everyone.
Good night.
Good night.
Good night, everyone.
Good night.
Good night.
From the isolation center as I came out.